All right. So this one was also a little dense. I'm going to try to move through this one a little faster if possible. Yeah. So. All right, so we're going to talk about just some intro things: neurological control of the GI system, normal phys, the GI tract, GI changes after SCI, bowel management, and then potential GI complications. So after saying that, bladder is number one, why is number two number one? All right. So they're both really important. They're both really important. But on surveys, the number one reason why patients don't leave the home is the fear of bowel accidents or the reality of bowel accidents. So, we just spent an hour talking about how important the bladder is. Well, the bowel is equally as important, in my opinion. Because, here we're taking care of folks, but the goal is not so that they just stay at home when they get back home, right? That's part of the transition. You want to get people home, but you don't want to just get them home. You want to get them back to their life. And that's why we do what we do. So bowels are the number one reason what prevents people from getting back outside of their home and into their lives. All right. So as far as the neurological control of the GI system, there's two main things that we're going to touch: the enteric nervous system and the autonomic nervous system. So with the enteric nervous system, if you guys remember, the myenteric plexus, the submucosal plexus, those are Auerbach's and Meissner's. These are sometimes actually, they pop up on your boards or on the SAEs occasionally. But just remember, myenteric sounds like muscle, right? So that's the contraction. That's contractility, motility of the GI tract, the colon. It moves the stool forward. Submucosal, okay, sounds like it could be related to secretion and absorption. All right, so pretty simple from that standpoint. But that's the enteric nervous system. It can run on its own. All right, it's just there. But even though it can run on its own, it is influenced by the sympathetic and parasympathetic nervous systems. All right, so as far as the autonomic nervous system, like we said, parasympathetic and sympathetic. Now, the parasympathetic nervous system really is, there's a couple things that, I want you to gain from this. So the vagus nerve is what innervates from the esophagus to the mid-transverse colon. So that provides parasympathetic innervation from esophagus to mid-transverse colon. Pelvic nerve is from transverse colon to the rectum. All right. So just keep that in mind as far as when we're talking about, spinal cord injury and what's affected. Primarily, it's the transverse colon and beyond, right? Because vagus nerve is intact in spinal cord injuries. It should be, all right? That being said, again, remember, because of the influence that parasympathetic and sympathetic has on the enteric nervous system, high-level cervical injuries can still have higher issues. But for most of our paras, it's an outlet. It's the descending colon, it's the mid-transverse colon and on that's you're having problems. All right. So the sympathetic nervous system, you have your superior and inferior mesenteric and hypogastric nerves. All right. And if you just remember kind of rest and digest and fight and flight, that's kind of the general input of parasympathetic and sympathetic on these systems, okay? All right, so normal phys, just kind of the stages: mastication or chewing, deglutition, swallowing. You got your stomach, intestine, pancreas, liver, colon, defecation, and reflexes. So we're just going to kind of fly through some of these things. This is probably more detail than you need to know, but remember salivary amylase, kind of breaking things down. All right, and then your swallowing, you got your oral, you got pharyngeal and esophageal stages. That again, vagus nerve innervates esophagus down, so that's what's controlling the peristaltic waves moving the bolus down esophagus. And then looking at just that sphincter, as long as it relaxes, when the bolus reaches it, gets it into the stomach. And then from the stomach standpoint, it's kind of the reservoir for the food. It's mixing it, breaking it down, smaller particles, and then regulating it passing through. So then you get to the small intestine. Primarily, you're getting further breakdown. You got your amylase, trypsin, chymotrypsin, lipase, all these other bile acids. Everything's mixing in to kind of break down and absorb nutrients. And again, even the myenteric plexus is involved in the stimulation of propelling food through the small intestine. So then you get to the colon, you got your cecum in the right lower quadrant, then it comes up to the ascending, transverse, descending, and then down to the sigmoid colon. Rectum and anus mark the end of the colon. Primarily ascending is for absorbing electrolytes and water, descending for storing the fecal matter till you evacuate. All right. As far as the normal colonic transit time, it can take anywhere from 12 to 30 hours. So if you think of, most people, you can go twice a day to once every 2 days, and that's considered normal. And if you go 3 times a day or more, sometimes people call that, diarrhea. If you're going 3 days without having a bowel movement, that's, people talk about constipation. So those are kind of those things. Now, as far as colonic motility, you have your hostrations, those circular muscle contractions for mixing, all right? And then you got these mass movements that actually propel the stool forward. Usually occur a couple times a day, and that can last for 10 to 30 minutes. Some of that kind of corresponds with when you feel like, oh man, I need to go to the bathroom. And then you're like, if you're not around the bathroom, you're inaccessible, you're busy, you kind of shut that down. And then you're like, wait, I don't need to go anymore. All right, so that's kind of some of these mass movements. That's what practically, what's going on. All right, now with the sphincter, there's an internal anal sphincter, smooth muscle, continence in resting state. Usually it's just tonically contracted, all right? Then you got your voluntary external anal sphincter. That's pudendal nerve. You got your voluntary control with the defecation and prevents incontinence, along with the puborectalis muscle during cough or Valsalva. All right. So when we talk about the neurogenic bowel management, we add reflexes because this is where our program stems from. These are some of the big reflexes that we kind of need to be aware of. The top 3 are probably the most important for you all. Gastrocolic, the idea that when your stomach is filling, that the colon needs to make room for what's coming through. That's all that is. So stomach distension, you get reflexive contractility of the colon, and it's trying to move things through. So practically on the floor, that's why we say, all right, we're going to give the suppository within 30 to 60 minutes after a meal, because it's already priming the pump for that. The colocolonic reflex is it's mediated by Auerbach's or myenteric plexus, and it's, again, that contractility. You get the proximal contraction, distal relaxation is moving things through, slowly but surely through, okay? And that's going to be important when we talk about our bowel program, because one of the medicines we use stimulates that. And then the rectal colic reflex, which is pelvic nerve mediated, that's what the suppository or digital stimulation affects. So you get a chemical irritation, you get a stretch mechanical irritation, and in the rectal vault, that then triggers a reflex that if there's anything higher up in the descending colon, you get contraction from above, relaxation, and you get the stool to come out. All right, now the rectal anal reflex and the anorectal reflex, they're just kind of involved in that final, when it's like right there in the rectum and ready to come out and defecate. That's kind of what that part is about. All right. Now, so as far as the normal defecation pattern, there's colonic contractions. Again, the stool moves from the colon to the rectum, that reservoir moving down. You get the reflexive relaxation of the internal anal sphincter, that conscious urge to defecate, and then under voluntary control, you get the external anal sphincter and puborectalis muscles relax, and then everything comes out. So this, as we found out early on, is Justice's poopy face. So I thought it was appropriate for the lecture. When we saw this, we knew he was going. All right, so so GI changes following SCI. So sometimes we run into issues with dysphagia, decreased gastric emptying, prolonged mouth to cecum transit time, decreased colonic motility, increased gallbladder disease, and then anal sphincter tone issues. So again, dysphagia we primarily see not as a result of a spinal cord injury, but as a result of surgery. Usually the anterior cervical surgery, the anterior approach, is causing a lot of swelling. You imagine there's a lot of swelling up here, that's what causes the dysphagia. And things don't work as well when everything's so swollen. So that usually improves with time as the surgical site heals. Decreased gastric emptying, like we talked about. In the higher level, kind of the tetraplegics generally, we see some decreased gastric emptying. And then prolonged mouth to cecum transit time. So like we said, normal can be 12 to 30 hours. It can double after a spinal cord injury, that whole kind of everything can slow down, and especially the descending part, from transverse, mid-transverse, distally, it can really double as far as the time for that transit. Increased gallbladder disease. There's been some literature showing that that in injuries above T10 with the sympathetic supply to the gallbladder originating between T7 and T10, that you can have some issues because of decreased sympathetic input. All right. Now, the big goal of our bowel program, bowel management after spinal cord injury, is to establish a predictable, regular, thorough evacuation, bless you, of the bowels without any incontinence, and then preventing complications. So this is just simply a KUB of somebody who's FOS or full of stool. All right, so things to consider. When you're talking with patients about, about what was your normal routine before? Were you like clockwork, after your cup of coffee in the morning? Did you go at night? Did you go multiple times a day? Were you once a week? Like, all that matters, because again, this is likely going to be whatever they had before, it's going to be prolonged even more. So kind of getting a sense of what they were before helps. For somebody who maybe went twice a week, okay, you might have some real problems trying to get somebody to go every day, because that's just not how their GI tract works. All right, so we need to kind of get a sense of what things were like at baseline. And then looking at diet, nutrition, pharmacological things, neurological condition, what's going on with them. Is there somebody that could be at home with them potentially, or do they not have hand function? Do they need somebody to help do the program for them, put in a suppository, stimulation, all that. And then just some of the big picture home stuff, activity level, what are their plans for returning to school or work. All right. So as far as food goes, there's certainly, you want to see what are they eating. Certainly foods that historically to them, or to people known to increase flatulence, that can be a problem. It can affect some of the comfort, discomfort, and moving things through unexpectedly. Spices and fat can definitely kind of stimulate things and move things through and cause some diarrhea. From a fluid standpoint, generally we're telling people probably 2 to 3 liters a day, right? But then in combination with the bladder program, if they're ICing, then you're probably trying to keep it to the 2-liter side, all right? But certainly if you're not drinking enough, then chances are, you could be more constipated. Fiber, there have been a lot of things looking at fiber. Some people say, oh, high fiber. Some people say low fiber. Most people probably at this point say avoid high fiber diets. 15 grams a day, okay, that's all right. But if you put too much fiber in and they're not drinking enough fluid to keep up with things, you're potentially causing more issues with constipation. Now, from a pharmacological standpoint, these are kind of the general categories of meds that we use: stool softeners, bulk formers, stimulants, contact irritants, laxatives, and enemas. And we'll kind of talk about the importance of using this with their medications and their fluids. So stool softeners, primarily on the floor we have Colace. There's another version, Docusate Calcium, which is Surfac. Basically it's there and keeps the stool soft, water in the colon. All right. Now, one of the important things as far as a stool softener goes, from a practical standpoint, when we're talking with the patients about the bowel program, the specific questions that I would ask pertaining to the stool softener is, what's the consistency of the stool? Is it too hard? Is it too soft? Because that's really what you're affecting with the stool softener. You don't want it to be so soft that things aren't moving. You want it to be too hard that things aren't moving through. So semi-formed, kind of semi-soft, those are some people will say even I hope this doesn't ruin it for you guys, but like that soft serve ice cream, that consistency where there's some form, but it's soft, right? That's okay. And then, so that's primarily consistency of stool is looking at the stool softener. All right. Now, bulk formers, some on the floor, what we have is Metamucil. It's psyllium. So that's the same as Fibrol and Natracil. There's some other forms of that, Fibercon, calcium polycarbophil, and Citracel, methylcellulose. These are all kind of that fiber supplement to help bulk a little bit and kind of move things through a little bit. But again, with this, you have to be cautious that you need to make sure you're drinking enough water. because if not, you can constipate yourself. All right. Now, the peristaltic stimulant, so Senokot, the little brown tablet. Sena is, you should, try to remember this for your SAEs and boards because sometimes they ask about this. Sena works colonic peristalsis via Auerbach's plexus, right? Meissner's plexus. All right, it's that enteric nervous system. It stimulates the contractility, the propulsion of the stool through forward. Okay. Now, there's two potential issues with long-term Sena use that you want to be aware of as well. It can sometimes stain the gut. So on colonoscopy, when somebody's looking at the colonic mucosa, they're like, hey, there's some staining on the wall. You can see staining of the colonic mucosa with chronic Sena use. Now, people have looked at it. Anytime there's something abnormal looking, what do people do? They biopsy it and send it to Pat. So they've done this for years. It's not precancerous. It hasn't been linked to any colon cancer or anything like that. But because it looks weird, everybody sends it off. So if somebody's on chronic use, Sena, and when they're going to go to their colonoscopy, you prep them and say, hey, tell your GI doc you're taking Sena because they might see some staining on the wall. All right, the other thing, so that's called melanosis coli. The other thing that you can have as an issue of Sena, if you think of it just like your body can build tolerance to opioids, right? And you need higher doses to be effective. Well, same thing with Sena. Your body can kind of gain some tolerance to it, develop some tolerance to it so that it's not as effective, and it can get to the point that the colonic wall actually dilates and you get this distension and it's just it's like atonic. So those are the potential complications. Now, typically Sena works somewhere in the range of 6, 8, 10, 12 hours, and everybody's a little different, but usually we're looking at timing Sena with a suppository. We want to give enough time to allow that colonic stimulation to move things through. Okay. Now, another stimulant that sometimes we use on the floors is like Reglan, and that's, again, primarily for gastric emptying. You want to be careful because, again, you can run into some of the side effects of Reglan. Cautious in elderly and things like that. Okay, dopamine antagonist, cholinergic agonist. So just be careful about that. And then people with MAOI inhibitors or antidepressants. All right, contact irritants. So this is the trying to stimulate that rectocolic reflex. So what we use on the floor, bicicotal, suppositories. They also come in, you can have like oral bicicotal tablets. There are some forms of what's called enemas. Enemas is like a liquid-based enema, stochastate sodium or cholase, mixed with polyethylene glycol and glycerin. Now, interesting thing with enemas is it's the only item on the market that has a formulation that is advertised as minimizes autonomic dysreflexia. So it's got a benzocaine, a kind of a topical anesthetic agent mixed into the enema itself. So for people who can get dysreflexic, they say, hey, we've got literature to support that this can help decrease your risk for dysreflexia during the bowel program. So use enemas plus. So it's an interesting concept. The part that I don't understand is, again, you're using reflexes to use to kind of get things moving. And if you're saying that you're adding a topical anesthetic agent and blunt that kind of noxious stimulus that is triggering dysreflexia, how are you not blocking that irritant to cause the reflex contraction? So I haven't figured out that part yet, but I've given it to patients because they like to send me samples. So I say, hey, free samples. Let's give it to the patients and see if it works. I've had patients use both, and it works. But I haven't really actually heard a whole lot of people saying, oh, this one definitely decreases my dysreflexia. But a lot of people, again, they're like, hey, I got my system, and I'm good. I don't need it. So it's kind of a newer product, enemas. All right. I'll also mention here, so there's, for the bicicotal, there's another form of it called the magic bullet suppository. So on the floor, bicicotal, it's a vegetable oil base, but this other form, magic bullet, is polyethylene glycol based. So it's water based. So you have an oil base and a water base, or fat soluble, water soluble. And if you imagine, in the GI tract, probably water soluble absorbs quicker. So there's a doc out in Seattle, Steve Steens. I think he's at the Seattle VA, Puget Sound. And he published the study looking at Magic Bullet suppository. It decreases the bowel program time by 50%. So whereas a Bisicolta suppository might take anywhere from 20 to 30 minutes sometimes, the Magic Bullet can work in maybe 15, 20 minutes, 10, 20 minutes. So that came out, and he's actually paraplegic himself, and I think the report is he did the study on himself. But so it's another formulation that's available outside of here. We don't have it on formulary, but it's a good option. All right. And an important thing to note is that in order for a contact irritant to work, it has to contact the rectal vault. Meaning, so before you put in a suppository, really what should be done is, lubricate, glove up, and see is there any stool in the rectal vault. Because if you're just putting it in stool, it's not touching anything. It's just sitting in stool, and eventually it might just work its way out because of rectal, anal kind of rectal reflexes, all right, just kind of pushing things out at the end. But you're not really getting that big rectal colic reflex to get more out. So you got to make sure that it's contacting the rectal vault. Okay. Now, laxatives, milk of mag citrate, fleets. You got your saline laxatives, and then you got your hyperosmolar, the polyethylene glycol, lactulose overall. So I like to just remind people with polyethylene glycol or Miralax, what a lot of people use. You see commercials, they got on the floor everywhere. Miralax is pretty popular. It's a cup of Go Lightly. All right, Go Lightly is that colon prep. Polyethylene glycol, same thing. So you're just essentially of that with Miralax. Now, when people say with the polyethylene glycol formulations, you're less likely to have electrolyte disturbances with these laxatives. All right. And then with enemas, there's like a whole slew of different enemas that are available. Mini fleet enemas, 30 milliliters of saline, mineral oil fleets, 133 to 250 milliliters. Tap water enema, a liter. Soap suds, a liter. And then smog. This came out of Texas. It's a 3-part enema: saline, mineral oil, glycerin, and then this sounds horrible, but hydrogen peroxide. And that's kind of in order of lowest to highest potency. I've never used smog or hydrogen peroxide. I've seen soap suds used once, maybe. I use tap water a fair amount on people who are fairly constipated, and usually that's sufficient. But sometimes you just have to have some other backup options in case things aren't moving. But we have Fleet's mineral oil and tap water. I mean, we could do soap suds. It's just basically getting soapy water. That's all that is. And so you're adding some irritation. That's all that is. So I'm sure we could do soap suds. There are other types of suppositories, yes. So there's some, and I imagine that that's also irritating, bubbly kind of, like imagine putting, what is that? Like one of these dissolvable things that kind of bubbles. It's probably more irritating. I came across like there was this guy who was injured in '85 or whatever. He came, saw me for the first time. He used this like old suppository that I'd never even read of. I forgot, it was this weird name. I was like, I had to look it up because I wasn't familiar with it. But there are all sorts of formulations, and he actually said that one for him, he gets dysreflexic otherwise. But this old suppository that works for him, he doesn't have dysreflexia. So I need to look. I think it's called mesalamine. I've never seen anybody else use it. I mean, I've seen glycerin suppositories used and all these other things, but
Something's like this for like 5 years.
I'm not. I don't know if that's what it is actually. I'm not sure. I'm just kind of throwing that out there. I'm not sure if that's what it is, but I haven't seen anybody else use it. So it's just interesting. Maybe it is that though. Yeah. So kind of like, so we talked about it a little bit earlier, things to consider before. You want to know what their prior bowel habits were, frequency, time of day. And you want to take into consideration an upper motor neuron versus lower motor neuron bowel. And so primarily you're looking at your rectal exam and with reflex testing. So in the past, people used to do bulbar cavernosus reflex. Some people still probably do that. And it's, you squeeze the tip of the penis and you would get a reflexive contraction of the external anal sphincter if that's intact, if that reflex is intact. And if it's intact, then you would expect that it's an upper motor neuron injury. Now, the thing with some of these things is, when somebody comes in with an injury, you can see what's called spinal shock. And spinal shock is the absence of all reflexes. So it may appear that somebody has a lower motor neuron bowel, but they may just be in spinal shock, and a week later or a couple of weeks later, you might see some of these emerging reflexes, and you say, okay, all right, this is really an upper motor neuron injury. So those are some of the things that I think, you gotta be aware of. When we do the ASIA exams here, I think with the pinprick exam, testing S4-5, you're already within a centimeter of the anal mucocutaneous junction. So with that noxious stimulus, you can see the anal wink if it's there. And so the anal wink is another reflex that then you can say, hey, this probably points to an upper motor neuron bowel. So that reflex is intact, and likely if we use a suppository, digital stimulation, that irritation, we'll get that rectal colic reflex and get things out. So those are some of the things that I look at on the exam. And with the rectal exam, again, you're looking at the continence. Do you feel that tightness? How's the rectal tone? So the goal also for the bowel program, you really don't want to take much more than an hour. I mean, if you imagine, like, who wants to have a bowel program that takes that long? It just wastes too much time. So we say under an hour, really, if somebody can get it within 20, 30 minutes and be done, ideal. That'd be awesome. I have a low threshold for checking a KUB because, sometimes people come in and they're like, I haven't had a bowel movement in 10 days. All right, so you expect that they're probably pretty constipated and backed up. But sometimes you see some people who are like, oh, I'm having diarrhea, I'm having loose stool. And you're like, and so then the nurses reflexively may say, oh, let's hold the medications. But if you haven't really gotten a sense of what's going on with this patient may actually be constipated, and the only things that are coming through are what's soft and liquidy. So you may only further complicate that by holding all these bowel medicines. So if I haven't really gotten a sense of what's going on with this person's bowel, just check a KB. Simple flat plate, quick, just see what it looks like, and then you can adjust from that. Okay, and then education. That's really for patients. So a lot of times, a lot of people are really resistant. You imagine, we talk with all these people about catheterizing themselves. They're like, you want me to do what? Like that's crazy. These are unnatural in a sense, unnatural things that people don't just naturally say, oh, let's do this, right? You don't think of emptying your bladder by catheterizing yourself normally. So likewise, when we talk about bowel program and digital stimulation, they're like, you're telling me to put my finger up what? It doesn't, it doesn't jive, and people feel really awkward about it and weird. But if you educate them and you explain why we do this, I found by and large, people are a lot more receptive. When I tell people, hey, again, this isn't my favorite thing to talk with people about, but when you have to catheterize and protect your bladder and kidneys, because so many people died from this years ago, like, we know better now. Like, you should do this because it's safer for you. Then they get it, And same with the bowels. When I explain to them, when we do the digital stimulation, basically you can either do that exclusively, you can do that after the suppository, you can do that before the suppository, but it's the best thing because that's how you know when you're done. So I'm going to get there. Hold that thought. So with the typical upper motor neuron bowel program here, you may see or you may hear what people refer to as 3-2-1. All right, so that's Colace 300 milligrams POTID. All right, Senna 2 tabs in the morning, and then a bisacodyl suppository at night within 30 to 60 minutes from dinner. So that's that 3-2-1 program that we use here. Use 3-2-1 outside of here, people will be like, what are you talking about? So this is just kind of vernacular internally here. Maybe some other people use it as well, but largely you go talk with the internal medicine doc, 3-2-1, they're like, contact, or like, like it doesn't make any sense. So, all right, for maybe the older people in the crowd, sorry. All right, so anyways, again, we want to use this starting point. That's all this is, a starting point, because you're asking the patient, what's your stool consistency? If it's too soft, 3 is too much of Colace. All right, back down. If it's too hard, we might need to add more, okay? Or add something on top of it, maybe some Miralax, something, all right? And then with the Senna, again, kind of pushing things through, and then the suppository getting things out. So try to make use of the gastrocolic reflex, tying it in with their meal, and then we can adjust things. Now, if we adjust things to the bowel program, usually what I tell people is tell patients is it can take 3 to 5 cycles, 3 to 5 days to really, see the full result of it. And that's for if we're doing it every day. So for some of our patients who aren't doing a daily bowel program, outside of here, I've got one guy who does this once a week. If we wanted to change something once a week, and he only does this thing once a week, it might take 4 weeks, 3 weeks, 5 weeks to really see the full effect of that, all right? So that's what it means by taking 3 to 5 cycles to really see the full effect. So if somebody does it every other day, okay, it might take 6 days to 10 days to really know the full effect, okay? All right. So another tidbit, caffeine can help stimulate and help facilitate fecal evacuation. Warm liquids, so sometimes people said, coffee or tea in the morning. There's actually some laxative teas, Lacey Lebeau teas, Senna tea, things like that. Now back to the digital stimulation, and education. So the important thing about the bowel program and digital stimulation is that this is really the most reliable way of knowing when you're done. So again, when we're using reflexes to kind of trigger a bowel movement, you're saying that you got the colonic kind of contraction after a rectal stimulation, either chemical irritation or stretch, mechanical stretch. So if there's anything in the descending colon and rectal vault, that's what's going to come out. You get contraction from above, relaxation from below. But if you're done, if you're empty, there's nothing left, there's no reflex to react to. So you do the stimulation, there's no proximal contraction, there's no distal relaxation. So what you tell patients is that with the digital stimulation, because if they're doing digital stimulation, they can feel in their hand. They have hand function, hand sensation, right? If you're doing the digital stimulation, if there's nothing left to come out and you're done, the sphincter stays tight around the finger. That's how you know you're done, because the reflex, it's not reacting, because there is nothing else to come out. So that's the best way of knowing how you're done. So again, the number one reason why people don't leave the house because of bowel accidents, this is how you know when you're done. So when you explain it to people that, hey, you know what, I know this isn't natural, this isn't what any of us really want to do, but this is your ticket to being outside. This is how you know accident. Confidence that you can go out for the rest of the day and say, hey, I'm good. I don't got to wear a diaper, or I don't got to, because people just want to get back to their life. So digital stimulation is the best way to know when you're done, all right, because you feel that sphincter still tight around the finger. All right. Lower motor neuron bowel. This really is challenging, because here you have an incompetent sphincter, decreased rectal tone, kind of these reflexes that don't exist, they're not working, and you will just constantly leak throughout the day. So the mainstay of lower motor neuron bowel management is bulking with fiber and manual disimpaction. And people hate it. People absolutely hate it. I took care of this. I'm still currently taking care of this guy who, unfortunately, has a lower motor neuron bowel. He was a guy who was like a vice president of a national company out in California, pretty big time, well, at least what he makes it sound like. But he was making 6-figure salary, company was paying for his car, he was living the life out in Cali, doing great things. But he had chronic back pain. He's getting epidurals. For those of you, be very careful. He's getting epidurals. It was helping for a while, but then eventually it wasn't doing enough. So they said, all right, time for surgery. Goes to surgery, whatever, reputable surgeon, this and that, gets the surgery done. He's fantastic. That first week post-op, he's in therapy. He is doing so well. The second week, he started developing back pain, severe back pain. Calls the surgeon's office, and they say, all right, well, we'll see you for follow-up. Surgeon walks in 5 seconds, looks at him, doesn't touch him, doesn't examine him, says, you just need more therapy. And so he writes him a script. He goes to therapy. He can't make it to therapy because his pain is so severe. So he goes to the emergency department. In the emergency department, they scan him, they do all this stuff. He's in so severe, he's writhing on the ER gurney, the table, right? They're giving him pain medication. And they just think, so they're giving him pain meds. His pain is not subsiding. So they consult pain medicine, pain management. They come and see him. They're like, how much pain medicine have you gotten by now? This, I don't know. Meanwhile, this is 12 hours, 18 hours, 24 hours later, right? They're like, you should be knocked out at this point based on how you eat. So they talked to the ED physician. They're like, we need to rescan him immediately. They rescan him. They found this whopping hematoma, epidural hematoma, right at the surgical site. They go back and look at the original CT. It was there. It was so big they missed it. The discs. It's this whopping, massive epidural hematoma. So now what's going on? He's having all this pain. He's got cauda equina syndrome. He's not controlling his bowel or bladder. And they missed this. All right? So immediately, emergent evacuation of hematoma. Now, 24 hours later, you know, not good. It wasn't very fast as far as picking up on these things. So, of course, you know, this sounds, and it really was, a lawsuit. Major. You know, this guy, you take somebody who's super productive, now he's incapacitated because of pain, can't walk, can't do anything. Bad news. All right? So that's what happened. He lost everything over there. Like he blew through his savings, had to move home to New Jersey, and that's how he ended up over here. He was staying with his mom. But just, you know, this is crazy. So basically, by the time I saw him, I was doing pain management because of his ridiculous cauda equina syndrome and bowel bladder stuff. But he hates his bowel program. Every time I see him, he's like, Doc, is there anything new? And I tell him, well, there's some things here and there. He's like, no, I don't want surgery. I don't want this and that. Just, it's rough. It's rough. So, but some other kind of, when we've talked through these things, you know, abdominal massage, kind of coming across, down, just helping move things through. But it's a really tough program. Again, it's, you bulk it up and you disimpact. He does this twice a day. It's hard. It's really hard. All right, so this is something to be aware of. There's this item called the Peristeen. It's put out by Coloplast. It's an enema continence catheter, and basically, you can see here, it's got a rectal catheter that somebody can put in themselves, and this little balloon pump. You have a dial here that you can select what it's kind of engaging. You can pump up the balloon so it holds in place. This reservoir here holds water. All right, so you can basically administer your own water enema. All right. So after you pump up the balloon so that it stays, the rectal catheter stays in place, you turn the dial, you pump in some of the water, and then you deflate the balloon, pull everything out, and it all comes out. Okay. So this is something that's coming on the market. It was recently FDA approved. It hasn't really gained a whole lot of headway yet, but it's an interesting thing because for some people who maybe have a little limited hand function, who maybe could insert the catheter but can't quite do digital stimulation, this might be an interesting option. It's kind of still, everybody's kind of feeling it out to see. This has been approved in use in Canada. You can go across the border and buy it. It's been used in Europe. It's just recently got FDA approval here in the US, I think last year. Now, some of these other surgical options. So there's this Malone procedure, antegrade continence enema or ACE procedure. So some people actually take the appendix, they loop it up to the skin, some straight through the umbilicus, and you can administer an enema. And it goes in through there, goes up, around, and out. And so you can kind of, from above, push everything through. And then, you know, some colonic irrigation and colostomy. So, you know, some people have asked, well, what about colostomy? And again, so by and large, whether you're doing interventional pain or anything, surgery is always the last option. You want to exhaust everything before you just jump to surgery. So it's not like, oh, okay, let's just do a colostomy. That's got to be your last option. You know, in order for you to get to a point that you're going to put somebody under anesthesia, put somebody under the knife, I mean, surgery is surgery. Some people don't wake up from anesthesia, right? So you still want to be very cautious. It's easy to be cavalier and say, oh, you know, I see people post-spinal surgery. You know, what's a little colostomy then? You know, and they can do it laparoscopically. Sure, but you still, you know, you just want to be a little cautious in moving forward with those things. We do see colostomies, however, though, and primarily in a couple situations. One, in traumatic bowel abdominal injuries. All right. Sometimes they'll do a diverting colostomy just because of the injury to the bowel. All right. Also, people with wounds who are undergoing a sacral flap. So if you imagine, you know, somebody's had a sacral wound and hasn't healed because it's been really bad. And if you're just constantly bathing that wound in stool, it's not going to heal well. So sometimes when somebody does a sacral flap, like a myocutaneous flap or skin flap, in order to do that, some people will require a diverting colostomy because they want to keep that wound clean. So sometimes you will see that, and it can be used in those type of situations, but that's kind of primarily where we see it: bowel injury and for wound healing. Complications after SCI, there are a lot of potential problems. I think that mentioning is superior mesenteric artery syndrome, SMA syndrome. I actually had a patient who upstairs was nauseated, vomiting, had lost a lot of weight after a spinal cord injury. Those are all triggers for SMA syndrome. So primarily what it is that somebody who has a spinal cord injury, they lose a lot of weight, muscle weight, fat weight, that abdominal fat pad is smaller. And so when they're lying supine, it compresses. And so there's an area on the, I think the second or the third part of the duodenum where it crosses over the SMA, and there can be some pinching of that, and then that can cause this nausea and vomiting, abdominal pain. So we actually had somebody who was nauseated, vomiting, Friday, I think, and into the weekend. We're kind of like, I think we talked about it with the resident, hey, there's this SMA syndrome, and but it's pretty rare, and it is. But you got to be cautious in somebody who's losing weight and presenting like this. But so we kind of went through differential and said, hey, this and that. And she got really bad over the weekend. It was like bilious vomiting. So they actually got, I think, GI involved over the weekend. I think they put in a Daboff, or they tried to just kind of, give her bowel rest and just, NPO, all that stuff. And so then they went into, doing abdominal ultrasound, and the ultrasound was suggestive of a compression, and that there was something going on in the GI. So then we got a CT of the abdomen and pelvis, and sure enough, it shows contrast going through to that second part of the duodenum and nothing beyond that. And so we nailed this diagnosis of SMA syndrome. So we talked with GI, and really, again, this is all triggered from weight loss. So we had to figure out a way to help her gain weight. How are you going to help somebody eat who's nauseated and vomiting? So we had to put a J tube. All right, so we had to use the J portion because of this occlusion, basically. So we had to get it past that. So then the issue was, who puts that in? GI or general surgery or IR? How do you get it past this area where it seems to be kind of obstructed and blocked? So that was something we had to work through. Eventually we got that done. We got her on tube feeds with the J tube, and she bulked back up a little bit, and all her symptoms resolved in a matter of a week or two. So it's something that sometimes you might see on SAEs or boards. It's something to be aware of. It's not common, but these are kind of some of these things that a little esoteric, but people like to test. So.
If you had general surgery, could they manually also, while putting in the J tube, sort of bring that area?
So some of it, I guess physically, yeah, you could kind of manipulate some things, but it's primarily because of the loss of the fat pad and just how things compress when you're supine. So some people will say roll them on their left, kind of a left lateral decubitus position, so that helps relieve that decompression, or it relieves the compression when you're rolling on the left. So a lot of it is just when you're eating. Normally it's after a meal especially, and everything's compressing down this way on your back. So, but by the time, she had advanced pretty significant, bulk her up, get some fat back on her, because she was tiny. She was like 90 pounds. She was a little thing. Yeah. And then hemorrhoids is worth mentioning. Imagine with the bowel program and, sitting on a commode or a toilet for a while longer than normal, you're going to run into some issues with hemorrhoids, internal, external. General management, external, you're using topical creams. Internal with, if there's bleeding and you don't see it, or irritation, you can use hemorrhoid suppositories. So, all right. So summarizing everything, again, there's a lot of changes to the GI system, bowel function after SCI, can have profound impact on individuals in their lives. Understanding the physiologic functional changes after SCI helps guide the management. and then being aware of a lot of the potential secondary GI complications. All right. Any questions?
A couple questions for you. The PO vesicle, that's like a contact irritant. I get why it works as a suppository.
Yeah.
Why does it work when it's taken PO?
Yeah, it helps push things through.
Okay.
All right. I think it really helps to kind of induce some of that contraction and moving things out. My reservation to using that is if you're using it because somebody hasn't had a bowel movement in a while, if you don't know the stool consistency, if it's really still rock hard, you're not going to move that anywhere. So if maybe it's just been a couple days and somebody's uncomfortable and you're just trying to help them, I think that'd be okay. Some people get some cramping with that though. And it is effective, but if you're talking about somebody who's got hard stool, you're trying to push a rock out. That in and of itself won't really be that effective. So I'd probably go down the route of, if you really think it's that hard and you need to move things through, a liquid enema or something from above, milk of magnesia, magnesium citrate, even just a half bottle, 150 cc's if needed, just kind of pushing things through. Lactulose, I mean, you can use all sorts of different liquid agents, pushing things above and getting things out from below. Yeah.
And then with the Senna, how long is long-term use where you start seeing those issues and like you would take breaks with it to prevent that?
Yeah, good question. So a lot of what we see here is on the inpatient side. We're managing things anywhere from 4 to 6 weeks, sometimes 8 weeks, right? And then they go home. So once they go home, sometimes it's, well, who normally eats hospital food at home, right? So the diet changes for better or for worse, right? And so you sometimes have to adjust the bowel program with that. So there are a lot of people who aren't on any Colace, any Senna at all, no suppository. They're just diet-based, diet-controlled, and then digital stimulation. So a lot of that gets changed and adjusted down the road once they leave. But primarily here, it's like building a routine, getting things moving, and just getting them started. Yeah. Any other questions? All right. Thanks.